pancytopenia in an older patient. Now, for example, it is more than 60 years of age, or let's say 65 years of age. Even in these cases, you would see a cellularity of 20-30% even as a normal. Now, this person has got a pancytopenia. I would rule out any myelodysplastic syndrome or any such issues prior to starting therapy for aplastic anemia in these patients. Let us say, the definition of elderly can change from person to person. It could be 55 or 60. Let us say we have got a 60-year-old who has got a pancytopenia. Cellularity is approximately 20 to 30%, just giving a number. And you have got a monosomy 7 which has come up. And you now start looking at some dysplastic changes in this person's bone marrow. This is a person who might do well with IST in the short term, but there is a very high likelihood that he or she will relapse or will progress to leukemia. So this person, 60-year-old, who has got a monosomy 7 or dysplastic changes, should ideally be taken off for a allogenic stem cell transplant. Now, for those patients who do not have any dysplastic features, or they do not have any of these cytogenetic or NGS markers for any kind of clonal abnormality other than PNH, in these cases, my go-to therapy would be immunosuppressive therapy with antithymocyte globulin combined with cyclosporin and L-trombobag. This would be my option for treatment. However, as I have already shown you earlier, the choice for transplant versus IST would depend upon the patient's fitness, and that previous cutoff of 40 no longer holds.
Thank you, sir, for teaching us that even both extremes of age, we need to be particularly sure of the diagnosis before deciding what treatment is needed, and how fitness is very important to decide what treatment is needed. Next, we move to Ms. Sharanya from Datri organization. So, ma'am, for patients who don't have a fully matched donor in their family, then how can the families get other type of donors for transplant? And in India, what are the donor registries? And typically, what is the cost which is involved in getting the cells from an unrelated donor?
Thank you, Dr. Siddharth, for this question, and thank you, ISBMT, for giving Datri an opportunity to put forward our thoughts. So, to answer your first question, as Dr. Pravas said, that a family has only a 30% of chance to have a matched related donor. So, the rest of the option would be, the patient has to look for matched unrelated donors through a stem cell registry like us. So in India, we have quite a few registries. India, Datri being the largest among them, and we have close to 6.25 lakhs of registered Indian donors available in our database. So the patient HLA, we will get the HLA from the transplant center, and we compare it in a database. And if we find a suitable match, then on donor's consent, we go ahead with the collection process for the donor. And in some cases, if there are no matches available in Datri, we also collaborate with international registries through WMDA, which is World Marrow Donor Association, which connects registries globally. So this also helps patients to find those who don't have match in India can go for potential matches available in abroad. And to answer your second question, yeah, we have quite a few stem cell registries in India when compared to other countries, like Datri being the largest, and we have DKMS, Gene Bandhu, and MDRA, which is there in Delhi and Mumbai. And Datri contributes totally 70% of the total potential donors available in India. So in terms of cost, the domestic stem cell procurement from an Indian registry approximately varies from 6 lakhs to 8 lakhs depending on the requirements. And if a donor has to be procured internationally from other registries, the cost may vary, minimum being 20 lakhs, and it can go up to 45 lakhs is the highest range we have. Like registries like NMDP, it cost around 45 lakhs. So the main thing here is genetic diversity is a main role. So we need more donors to be registered as in Indian registry so that patients will get a chance to find a match within India.
Thank you, Sharanya ma'am, for telling us that now we have options for patients who don't have related donors also due to registries like Datri, and that families have to be prepared for that extra cost to arrange stem cells if there is an unrelated donor. Next, I move on to Jyoti sister. Sister, we know that Sir has told in the talk that patients with aplastic anemia have very low blood counts and therefore at high risk of infection. Can you advise our patients and their families how to take care of the general personal hygiene? Jyoti sister? Uh, am I audible? Jyoti sister, can you address this question?
I think we can move on to the next question. Maybe Dr. Siddharth, we will come back to Jyoti sister.
Sure. So back to Shweta ma'am. Ma'am, you were telling us in the previous question that children with aplastic anemia, they may be actually having an underlying genetic defect also. In that case, how does the treatment vary?
Yeah. So, Siddharth, I mean, it's very, very important for us to do a complete workup. We can't emphasize on it further because we know that if the child is having a idiopathic aplastic anemia or immune-related aplastic anemia, the treatment differs a lot when there is a genetic defect. One is that the child, we have to see all the organs, whether they are functioning well or not, because when we're talking about the inherited bone marrow failure syndromes, we have Fanconi's anemia, we have Schwarzman-Diamond syndrome, we have Diamond-Blackfan anemia, many other. And in these, multiple organs are involved. Hence, the fitness of each and every organ is very, very important, whether the heart is functioning well or not, whether kidney is a single kidney or horseshoe kidney, whether the patient, other like in Schwarzman-Diamond syndrome, whether the patient is having a pancreatic disorder or not. All these things which we need to rule out when we are working up these patients. Second thing is, if we know the genetic defect in these patients, our conditioning also varies. Because in certain conditions, we cannot give radiation, like in Fanconi's anemia, we avoid radiation during the conditioning regimen. Like in other conditions, I would say in telomere biology disorders, in which there is a shortening of the telomeres, like in dyskeratosis congenita. These names are heavy, I know, but we need to know about these disorders, and the conditioning gets completely differed. So all these things which we need to understand very well. One is conditioning, second is the organ thing, and third is the donor selection also. So when we are talking about the inherited cause, we have to do the donor evaluation also proper. Even if the HLA, if there is a full match in the family, we have to do a complete workup of the donor also to understand the donor is not suffering from the same mutation or the defect, because then our treatment will fail. Hence, a complete workup of the patients having a aplastic anemia, especially in the childhood age, is very, very important because it will affect our approach to the treatment, it will affect our conditioning, it will affect our donor selection as well.
Understood, ma'am. We all learned that if the patient has a genetic problem, then how the doctor chooses and doses the drug will be different. And we also have to make sure the donor, if he's related, should be also checked for the same genetic problem. Next, we move on to Pravas sir. Sir, when we talk about a full HLA match and a half HLA match, does it mean somebody with a half match has only a half the chance of cure or survival, sir? Pravas sir, should I repeat the
Yeah,
question?
yeah. Sorry, I'm so sorry.
Yes.
I was on a this thing. So your question is difference between a full match HLA and a half match. So this is just a when we talk about a best available donor. So the best available donor should be ideally a matched sibling donor who is completely matched at all the loci. So you do A, B, C, DR, DQ, and DPB1, right? All these six loci you can do it, and then that is a full match. Somebody has got just one loci mismatch, then that is, let us say if you have done 8 antigens, then it is 7 by 8. If you have done 12, then it is 11 by 12. And a half match would be either a 5 by 10 or a 6 by 12. So this is the meaning of a full HLA match and a half match. So half match does not mean only half the chance of cure. In fact, far from that, a half match transplant might be better or equal to fully matched unrelated donor, or definitely better than even a mismatched unrelated donor. There are studies where even a half match has got similar outcomes like a match sibling donor transplant.
Thank you, sir. We understood that even if there is a half match, it doesn't mean that the chance of success is half. In fact, if there is no full match donor and the patient needs a transplant, we can proceed with the half match donor. I'll go back to Jyoti sister's question. We had missed that. So, sister, we were saying that in patients with aplastic anemia, because they are so prone to infections because of the low blood counts, how to advise their personal hygiene? Please unmute and answer this question.
Jyoti sister, are you there?
Dr. Khushi, could you please help Jyoti sister unmute?
Yeah, sure, ma'am. Ma'am, unfortunately, we are not able to find Jyoti ma'am here.
She's there. She's there. She's there right at the end, Jyoti Nehra.
So perhaps we'll move to the next question and
Yeah.
come back. She can take up both the
Oh,
questions.
yes,
from
ma'am,
the-
I can see.
Yeah. So we'll come back to Jyoti Sir when she's ready. I'll just move to the next question. So, Sharanya ma'am, see, we understand that there are many people who do come forward and say that they will donate their stem cells if they are a match. But when they get to know that they are a donor, do you face challenges in convincing them to come forward and donate the cells?
Yes, this is a most important question because absolutely this is one of the biggest challenge which we face in our registry. Though thousands of donors register with good intent, when they register, they always think that they need to help a patient. But when they are identified as a match, some hesitation develops due to fear, due to family concerns, misconceptions about pain or health risk, or their physician would say that please do not go ahead and donate, it will deteriorate your body. So at Datri we do follow very strong counseling process where our counselors explain the signs, safety and real life impact of donation on how a patient would survive if a donor donates. We also try to involve donors family members at the early stage. If at all the donor is an 18-year-old boy or a girl, we also involve the family during the early age, so that because family concerns plays a very big role in India. And I think over time, with better awareness in India and with real donor stories, our conversion rate has improved significantly because most donors agree once they really understand how simple and safe the process actually is. Yes, we do face challenge, but we are trying to overcome it with the proper counseling stages and making the potential donors talking to already donated donors. So all these extra efforts we do take to make things work. Yeah.
Thank you. And we hope the audience will take forward this message to the public that donating stem cells is a relatively safe procedure and we don't anticipate any major problems. So now I move to Jyoti sister. I think she's unmuted now. Sister, I wanted to take up two questions. One I previously asked you was patients with aplastic anemia are very prone to infections. So how to take care of the body hygiene and also how to take care of the environment of the patient to prevent infections.
Yes, thank you, Dr. Siddharth and ISBMT team. First, we educate the patient and patient relative regarding personal hygiene, like hand washing. We always instruct to patient and relative regarding hand washing, frequent, thoroughly do hand washing with a liquid soap, at least 20 seconds. In DMH, in our hospital, we are provided each and every room liquid soap to do hand washing. Then if water is not available, we can use sanitizer for hand washing. Then regarding skin care, we educate the relative and patient also. In our hospital, we using skin soap that contain 1% chlorhexidine gluconate and vitamin A for bathing. Also, educate to people, educate to patient and relative regarding bathing and clean clothing wearing. Then moisture, we advise to patient relative or patient every time. He always use gently lotion for prevent dryness and skin crack. We use the Venusia lotion. Then oral care also you suggest to patient. In our hospital, we use the chlorhexidine mouthwash, 0.2% for mouthwash. If patient having mucositis, then she can't do hexidine mouthwash due to burning. So we our doctor advise AB solution. A solution it contain Benadryl cough syrup, injection soda bicarb, hexidine mouthwash, or xylocaine viscous, same ratio, 1:1 ratio. Before taking food or anything, matlab juice or. And B solution, it contain tablet fork and tablet metrogen. It first crush it like a till powder and then mix glycerin, prepare the paste and apply on buccal mucosa. Then skin protection, avoid cuts and always whenever we are shaving, that time we use the trimmer. Then at home level, how to care in the at home level environment, minimize the exposure of uh, germs, avoid crowded place like market, and stay distance away from who are suffering from common cold, safely food handling, wash your hand before preparing the food, avoid raw and uncooked foods, then avoid bakery items. We educate the relative and patient also. We move on the next question. How to avoid dust and smoke? Yes, we always educate the relative and patient every time. He stay away from the construction site, especially construction site can carry fungal spore and bacteria that pose the serious infection. We keep window seal when construction is undergoing nearby. Avoid room that have been under construction or renewal until they have been thoroughly cleaned. Consider using a portable HEPA filter into the room. Avoid smoking. Do not allow any smoke inside the room or house and car. Do not use agarbatti. Smoke from inside can aggressive oxidizing stress lead to respiratory issue. Also educate the patient regarding personal hygiene, like hand washing, and stay up to date regarding vaccine, yearly flu vaccines.
Thank you, sister. So you explained wonderfully how we have to keep ourselves inside and outside clean. For our own body, you told us how to keep the mouth clean with mouthwash and hands clean with hand sanitizer and hand washing, and the body clean with regular baths, and also how to keep the environment also safe and free from smoke and pollution. Thank you. So next I move back to Shweta, ma'am. Ma'am, interestingly, you had told us about all the implications when a patient, a child especially, has a genetic problem as a cause of aplastic anemia. Suppose the donor is the child's own brother or sister and they look perfectly well, they're growing well. Can we not just assume that they don't have that defect? How would you address this situation?
Yeah, thanks, Siddharth, for asking this question. It's a very important question. As I said earlier, also, when we are diagnosing aplastic anemia in children, childhood age, then selection of a donor is also an important task. It's not just about the HLA typing, it's about the complete workup of the donor is also very important. And as you have asked that maybe the donor is looking completely normal, but that doesn't mean that it is equally the eligible donor, because many of these genetic disorders, they can present later. The child may look completely normal, and if we take that donor for the stem cell donation, then it can be a disaster, because not only the child may have a toxicity but also have a graft failure also. So I think the complete workup of the donor is very, very important. So what we do in our center is that any child who is diagnosed with with the aplastic anemia and is eligible for the transplant, then we do a complete workup of the donor, in which we include the CBC, complete physical examination of these patients, and also they go for a NGS and chromosomal breakage defect examination as well. And once the child is completely, don't have that disorder, or they don't have any problem, then only they are taken for a stem cell donation. In certain conditions, we can take a donor who is having a heterozygous disorder. It means that out of the two genes, one gene is only affected, and the child is not having any cytopenias, the bone marrow morphology as well as histopathology is completely normal, then only those can be considered for the stem cell donation. But we have to understand that whenever we are diagnosing the children with inherited bone marrow failure syndrome, we have to need to understand the inheritance pattern also. So if the child is having a autosomal dominant and the sibling is having similar defect but not exhibiting this condition, then we cannot consider that sibling or the family related family member for the stem cell donation. So hence the inheritance pattern of the genetic disorder is also very important to consider when we are considering the donor. And as I said, like the donor, even if it is completely normal, it doesn't mean that he's an eligible donor. Hence, complete workup of the donor is very, very important.
Thank you, ma'am. We have now understood that even if the donor looks totally normal, and particularly when the donor is related to the patient, we need to understand the doctor will do many tests and make sure that related donor is not carrying the same genetic problem. So next we move to Pravas, sir. Sir, we talked about this option of immunosuppressive therapy over a transplant. And now we have an Indian brand of the same medicine, which was previously many years back we were importing it. Is there a difference between the Indian and imported brands, sir?
So we are talking of the horse ATG, right? So we already had thymogram. We were using ADGAM earlier. These are what one would call as biosimilars. So one is, of course, when we are talking of tablet formulations, we talk of generics. But when we are talking of immunosuppressive therapies, we are talking about biosimilars. And to the best of my knowledge, there is no difference as far as the outcome is concerned between the two. There have been some publications even from the biosimilar brands, and they do have the similar outcome for these patients as well. I am currently not aware if there is a rabbit ATG in the Indian brand, but if you know it, I would be grateful to know that.
Thank you, sir. We were mainly concentrating on the horse ATG
Horse
for
ATG, correct.
immunosuppressive therapy. And I think, like you said, the Bharat Serum ATG is
Yes.
also working quite well in most of our centers. We'll move on to Sharanya ma'am from Datri. So we understood that there are registries which have unrelated donors who can give stem cells when they are a match. But because aplastic anemia, you need to do the treatment or the transplant very urgently. How can you expedite this process of stem cell donation in unrelated donors?
Yes. So Datri has facilitated close to 140 donations with respect to aplastic anemia. So even we have completed donation within 10 days from the time we received the search request. The main thing which is needed for us to expedite the process is to have a clear communication from the transplant center. So when the transplant center shares a definite transplant timeline at the very beginning, it really allows us to counsel the donor transparently about the process and the expected dates. So this clarity, what will happen, it will build the donor confidence and increase the chance of him, consenting for the whole process. This is one of the, this is one of the thing, even in Dr. Pravas slide, he had mentioned that donor search has to be initiated at the time of the diagnosis. So when aplastic anemia patient comes for consultation, I think the best way is to give us a definite time frame for the transplant, so that we can also start expediting process from our end. And also we have network of various collection centers, tie-ups with various collection centers across city in India. So this enables us to faster scheduling of donor medical health checkups and procedures. Thereby we minimize the waiting period and also the logistical delays.
Thank you. We have noted your suggestions to expedite the process. Now I move on to the question to Jyoti sister again. So, sister, we know that when we treat aplastic, it's not only about giving ATG or doing the transplant. Lot of other supportive care is involved, like giving antibiotics and other medicines. So, it's quite expensive for the families. Are there organizations and support programs which can help in this regard?
Yes, sir. Our government having some organization like Pradhan Mantri Arogya Yojana, then Prime Minister National Reliable Fund, then hospital bases and local support. Hospital social worker can help us. Community funding, online fundraising platform is available. Then Rashtriya Arogya Nidhi also available. Nowadays, DKMS fund also working. Then Julia Wings Foundation for pediatric patient. Her parent, if not affordable, this organization I know.
Thank you, sister. I think many of our people in the audience will be reassured that even though it sounds very difficult, but there are many people who will help and they can contact the social worker team in their respective hospitals.
Yes.
So with that, I come to the end of the panel discussion. Thank you once more for this opportunity.
Thank you so much, Dr. Siddharth, and all the panelists for discussing very practical aspects of management of aplastic anemia. So I'll hand over to Dr. Venkatesh for the final vote of thanks.
Thank you so much, Dr. Silky. And to start with, I wish to express my sincere gratitude to all of you uh, who have been part of this webinar and making it a success. In particular, I want to thank Dr. Prabhas Mishra for taking us through a case-based approach, which was quite in a challenging sort of a topic, and breaking it down for the patients completely, the decision-making process. I also want to thank our moderator of our panel discussion, Dr. Tutadri, for framing very relevant questions and taking us through a wonderful panel discussion by taking one issue at a time. Uh, Again, our esteemed panelists, Dr. Shweta Bansal, Sharanya from Datri, Jyoti sister, all of whom, and Dr. Mishra himself, all of whom shared their insights and their guidance over specific issues. I want to thank the ISBMT for hosting this webinar, and I want to thank our logistic partners, Mice Ideas, and our sponsors, Genova, for making this happen for all of you. Our next webinar is on the 13th of December. I invite you to join us between 3 to 4 p.m. And we will discuss about funding opportunities for BMT. With this announcement, I declare this webinar session as closed, and I hand over to the respective moderators.